the renin-angiotensin-aldosterone system and shock. This short video is on the renin-angiotensin-aldosterone system, a system that's quite simple to understand, yet still presents itself for opportunities for the case of muddled brain. This image is quite explicit, but busy, so we can take this circumstance to clear things up. The renin-angiotensin-aldosterone system functions under many conditions. With a focus on trauma in the recent years, we could use it to demonstrate some of the body's compensatory mechanisms in shock from blood loss. You have responded to a multi-systems trauma patient within minutes of injury. There are two primary formulas we need to be cognizant of. Cardiac output is a product of heart rate and stroke volume, and blood pressure is a product of cardiac output and systemic vascular resistance, or in some texts, peripheral vascular resistance. Whilst managing this patient, you undertake a few basic observations, and you find that the patient has a tachycardia and a palpable radial pulse that feels thready. The primary compensation in fluid loss is an increase in heart rate and stroke volume. This stroke volume is a quantity of blood that's ejected from the left ventricle. This collectively increases cardiac output. In the blood pressure equation, we understand how cardiac output can increase. Systemic vascular resistance or peripheral vascular resistance increases by offering resistance to blood flow by constriction of the systemic arteries and arterioles. This will cause a net increase in blood pressure. So blood pressure of 130/90 may not look so dreadful in your polytraumatized patient. Not quite so. The eagle-eyed amongst you would have noticed the diastolic seems elevated, and this may be due to a temporary increase in systemic vascular resistance. This primary compensatory mechanism is initiated by the sympathetic nervous system, which we know is a component of the autonomic nervous system. Adrenaline and noradrenaline is released. They have primary functions. Alpha-1 activity, which causes vasoconstriction and hence influences systemic vascular resistance. It also has beta-1 activity, which increases the heart rate and contractility of the myocardium. But what if these compensatory mechanisms failed? They often do in polytrauma. The patient continues to bleed despite your best efforts, and there's blood in the abdomen. Your circulatory system has baroreceptors. One of these baroreceptors is located in the carotid bodies. The arch of the aorta and the afferent arteriole of the nephron. Once these baroreceptors sense a drop in blood pressure, they will stimulate the kidneys to release a hormone called renin into the bloodstream. The renin-angiotensin-aldosterone system starts with the liver. The liver secretes angiotensinogen continuously into the bloodstream. We all know that the kidneys will secrete renin if the blood pressure drops. Renin will then convert angiotensinogen into angiotensin 1. Angiotensin 1 is in the circulatory system, and at some point this hormone will enter the pulmonary circulation, where by the action of ACE, or angiotensin converting enzyme, will convert angiotensin 1 into angiotensin 2, which is also circulated around the body. Angiotensin 2 influences many body functions, notably 4. It results in an increase in sympathetic activity. It then stimulates the pituitary gland to release a hormone called antidiuretic hormone, or ADH, that reduces urine output, hence retains water. It stimulates also the adrenal glands to release a hormone called aldosterone, which influences the kidney to also retain sodium. Sodium has a high affinity for water, so plasma fluid volumes are collectively retained. Angiotensin 2 acts also as a vasoconstrictor and increases mean arterial pressure as well. I hope that this short video has made the renin-angiotensin-aldosterone system a shade more clearer. Thank you very much for watching. I hope this was informative.